Welcome back to my channel. Today I'm going to be talking about a day in the life of being a respiratory therapist. My name is Daniel. Stick around to find out more about how an RT works throughout the day. I'm actually going to include a timestamp at the bottom so that you can get to know what I'm talking about. ICU versus ED versus floor care. That way you get to know the day in the life of an RT in each of these places without having to watch through something that you don't necessarily want to watch. So if you are interested in a specific area only, like ICU care or ED care or floor care for an RT, the timestamp is at the bottom. Hey guys, I'm Daniel from Dolier Media, and like I said in the intro, I'm going to be talking about a day in the life of being an RT. Now, full disclosure, I just started doing keto, so I might look a little slimmer than usual, so just don't be surprised or alarmed. It's just because I'm doing keto right now and losing weight. So today I'm going to focus on a 12-hour therapist as opposed to an 8-hour therapist. RTs usually work 12-hour shifts. There are some hospitals that RTs do 8-hour shifts. It's going to be pretty much the same thing on an 8-hour shift, but I'm going to focus on what I see the most of, which is a 12-hour shift. In terms of scheduling, if you're a benefited person or somebody who works full-time or part-time, you're going to do 2 days or 3 days a week. A lot of RTs that I know like to work 5 or 6 days straight, and then they get a bunch of days off. So like 8 days off, and then they come and do a stretch again. So RTs typically do stretches. This is common in the medical field for nurses and anybody else that does 12s, but this is something you're probably going to see a lot if you're working as an RT, or if you're trying to get into this, this is most likely how you're going to work as an RT. There are island days, so it's like you do 4 days straight and you pick up an extra day on like a day that you're typically off. That does happen also, but that's pretty much how the schedule is going to look like. Now, RTs that work 12-hour shifts usually start around 6:45. Whether it's PM or AM, and it's a 12-hour shift, you get off around 7:15. There are going to be some changes, but for the most part, that's what it is. And when you start at 6:45, this is kind of how your day is going to look like. Now, if you come in at 6:45, whether it's AM or PM, this is pretty much how your day is going to look like. I'm going to talk about day shift first and night shift. I'm also going to talk about the 3 areas of the hospital that you're most likely going to work at. I'm going to talk about ICU, ED, and the floors. Those are 3 areas that you're most commonly going to work out. Now, I'm not going to address RTs that work in outpatient clinics. If you work in a PFT lab or a sleep apnea lab or a sleep lab, this isn't going to be for you. So this is mostly inpatient RTs, and the 3 areas I'm going to cover are the areas I just mentioned. Okay, so area number 1. So let's say you're assigned ICU that day. Whether it's adult ICU, or it doesn't really matter if it's a neuro ICU, cardiac ICU, your work's going to be relatively the same in each one. Now, the treatments you'll do might be a little bit different, but you're kind of going to have the same flow no matter where you're at in what ICU. So day shift ICU, you get there at 6:45. Now, for the first 30 minutes, sometimes 15 minutes, you get report and gather information on your patients. You're assigned, how RTs do it is they usually get assigned points, and points determine how many minutes a thing takes. So let's say that a breathing treatment takes about 15 or 20 minutes, then you'll get a set amount of points for doing that. And how the work is allocated is for your 12-hour shift, you get an appropriate amount of points that works for the exact amount of hours that you're there. So some things might take a little bit longer and some things might be a little bit quicker, but on average, the point system is kind of how RTs are allocated in assignment. So if ICU is very slow, you actually might get another floor assigned with it, or 2 ICUs if there's not that many patients in the ICUs. If it's very busy, on the other hand, you might only get 3 or 4 patients in the ICU. So it kind of all depends on how much work you have to do with the patients, but you might see anywhere from 3-4 patients in the ICU to having 20 patients. So it all depends. Now at 7:15, your report's done. You could have been done at 7, you could have been done at 7:30. It all depends on how long the report was, how much information did you get, and also how much reading did you do on your patients. But roughly between 7 to 8 o'clock, you're going to start your treatments. Ideally, you're going to start around 7:15, and you're going to hit the ICU. Now, when you go to the ICU, how it works is you have a set number of things that you're going to do, most likely Q4 while awake or Q4. Some hospitals have Q2 checks for vents, so you will see your patients more frequently, but for the most part, a lot of respiratory treatments are every 4 hours. Q in the RT world or in the medical world means every. So Q4 means every 4 hours. So you're gonna go see all your vent patients. Now, if your vented patients have any kind of breathing treatments, you're gonna give them their breathing treatments. If they have any other modalities like a metaneb, which is a percussive device, or some kind of CPT therapy, any other treatments that go along with the medications, you're gonna do those treatments at 8 o'clock. Now, most hospitals have a window where you have an hour before and an hour afterwards where you're allowed to do your treatments, and you have to follow the RT that worked before you. So if the RT before you did their treatment late, then that patient has to be started a little bit late. So, like I was saying, your treatments start around 8 o'clock. You have an hour before and an hour after to do it, and you're trying to time it out to be exactly 4 hours after the previous RT. So if the previous RT did it at 5 a.m., you're most likely going to see that person last and see them around 9 a.m. You do your vent checks. You saw your, let's say, 5 patients. You gave them their treatments. You did everything you needed to do. You corrected anything that the doctor ordered in the morning. You did your ABGs if you have any morning ABGs. And now what happens is most hospitals have rounding somewhere between 9 or 10 o'clock. So if you're in an ICU, then you're going to go with the doctors or with the trauma surgeons or whoever the MDs are. You're going to have a team of professionals such as nutrition, dietary, pharmacist, nursing. There's even going to be a chaplain sometimes. So every kind of care that the patient has in the ICU, they're going to be addressed from every single department. And you're one of those departments. You're respiratory. So the nurse gives her report to the doctor in front of everybody, in front of the room, with the family members there watching or listening. And then what happens is the doctor says, how's the spiritual thing going? Which could be like a last rite prayer or some kind of other thing that was missing or needed. He'll address dietary and he'll say, hey, dietary, how's the diet going? Do we need to increase the intake of food? Do we need to decrease it? And he'll go through every department. And as an RT, you're going to talk about everything related to the respiratory system. You're not going to just kind of overwhelm them with unnecessary information. You're going to tell them any changes that happened. If all of a sudden they started getting a little bit more acidotic on their blood gases, you're going to tell the doctor. If the person got extubated or self-extubated and you had to re-intubate at night, you're going to tell the doctor that's what happened. If you had to do any SBT trials, which is a trial to see if they can come off the vent, you're going to let the doctor know at that time, oh, look, the patient passed their SBT trial. We could possibly wean or extubate the patient. So it's just your little window to really stay in touch with what's going on in the patient's care. Okay, so now it's, let's say, anywhere from 9 to 11 o'clock. That's usually when that happens. Now you have your extra things that you found out you had to do in the morning. It almost happens every single time you work. So let's say an ABG was not, somebody forgot to get an ABG on one of your patients, and you're looking over the patient chart, that now that you have a little bit more time to actually see what's going on, you're reading their history, you're reading any kind of notes that were taken and made, and all of a sudden you see that, hey, look, they haven't had something done, and I'm going to go do it. And so between that time, around rounds, you're going to do that. Also, around rounds is when the doctor is going to ask for things. Like the doctor is going to say, can you go walk with this patient on the vent? And you'll get up afterwards and do that. Or the doctor will say, hey, can we get an ABG right now? And so that's usually your window to do that. So between 9 and 11 o'clock, you're pretty much catching up on anything the doctor ordered that's new, anything that wasn't done before, and any other minor things that need to be done that's not like a big heavy thing. So if you need to change any filters, if you need to add your water bags, change your water bags, this is the time to do it. So now we have 12 o'clock treatments. So again, you have an hour before, an hour after. It's about 11 to 1 that you want to get all your treatments in, all your vent checks, everything else. Unless you're a Q2 hospital where you do vent checks or BiPAP checks every 2 hours, you're going to start doing your patients again around this time. So from 11 to 1, you're going to be busy again. You're probably not going to have a chance to eat yet. So you are going to be pretty hungry, But for the most part, it's the same thing as the first rounds, just not as intense, because in the first rounds, this is your first time interacting with the patient. Now you've already seen the patient, so you could see if there's any changes that need to be made. You're kind of more comfortable with the patient's family, with the patient themselves. So for your second rounds, they're a little bit lighter, and most likely you'll be done with your second rounds a little bit sooner than you were done with your first rounds. After this time is when most people take lunch. You're going to take your lunch, you're going to take your break, you're going to sit down. You have a little bit of a window where you don't have anything to do unless the doctor ordered something or there's some other interventions that need to be done. Typically, this is the time that doctors will schedule any CTs that they need to be done or any MRI exams. You have a little bit of a window where you can do extra things like that. If there's any bronchs, they're probably going to be done at this time. So anywhere from 1 till about 3 o'clock is a little bit of relaxed time. Now, that doesn't mean that you're not doing anything. It just means that you're not particularly with a routine. You're doing things extra and outside of what your routine is. And so this is, like I said, when you're going to do any transports or any talking to the family, if there's any meetings, this is when that's going to happen. Now come your final rounds, and your final rounds are around 4 o'clock. You start around 3 o'clock. You're going to be done around 5 o'clock, sometimes closer to 6. And around this time is when you want to make sure the patient's presentable for the next shift. You want to make sure everything's okay. All the water filters are changed. All the water bags are changed. If they're on a BiPAP, you want to make sure you've changed the mask or made sure they're comfortable. If there's any ABGs that need to be done, this is when you're going to be doing everything. So you're making sure that before you pass on the patient, that they're stable, that everything is okay with them, and you're kind of doing your final touches, making sure everything is okay with all of your patients. You're going to be done closer to 6 o'clock, most likely, with this round. It does take a little bit longer because there's a lot of things you have to do with the patients. Around this time is you're also catching up on things you might have not been able to do in the morning. And at this time is when you're going to be charting, making notes on your patients, and double checking that your day kind of went smoothly, making sure all your charting was okay, all your I's are dotted and all your T's are crossed. This is when you finalize everything that was done and prepare for your report. Now comes 6:45. You're already done with your report. You got everything ready. You wrote your little notes on all your patients, and now the next shift comes over and you give them report. Their shift starts. So that's how the ICU works. The ICU at night is going to be exactly the same as the ICU during the day. The only difference is that some patients are Q4 while awake, so you're not going to give them any kind of albuterol or any medications at night. So for the most part, vent checks are going to be Q4 or Q2. They're not going to change. You won't round with any doctors at night because that only is done in the morning. And it's going to be a little bit less of a hectic time, but at night is when all your surprise CT comes up or your surprise scans or tests or anything like that. There's a lot of random things that you didn't expect during the day, and all of a sudden at night, a patient starts, let's say, desatting and things start coming up. But for the most part, it's a little bit less hectic at night. You have a little bit more time to kind of clear your mind and really think about the patient. And that's why a lot of hospitals will make the night RTs change equipment. There's a little bit more time for them to change the suction canisters or kind of do some maintenance work. And that's kind of what's going to be different about night shift versus day shift. Day shift has rounds and family meetings, doctor meetings. Night shift has more of the busy work. You're going to do a lot more cleaning, a lot more things that like maybe turning around vents or anything like that. So that's your basic ICU day as an RT. This is again going on a 12-hour format. It's pretty easy once you get used to it. It takes about a year or two to finally get settled into the ICU. After about 6 months is when you finally start getting comfortable in ICU. So if you're just graduating or you're about to graduate, it's going to take you a while to really get into the groove of working in ICU. It's very intense, hence the name ICU, Intensive Care Unit. The nurses there are very knowledgeable. Doctors are super smart. The pulmonologists and everybody knows what they're doing. So you're going to be on your A game. And within a few months, you're going to quickly pick up on so many things that you never thought you knew. And so once you're on that ICU level of work, it kind of just becomes easy and it kind of becomes what it is. I personally prefer working in ICU. I think that's when I feel most, I guess I should say most as an RT. I feel like I'm doing the most help for the patient in the ICU. Even though all the work we do in the whole hospital is helpful, in the ICU is really when things are critical. The patient can go any minute and things are very intense oftentimes. There's a lot of codes in the ICU. You're going to have code blues maybe once a shift, depending on the hospital you work at, sometimes 5, 6 times a shift. If you work in a trauma ICU, that's even more intense because you're going to do a lot more stuff with muscles and neurons and things that you don't even think about on a normal ICU. And by neurons, I mean you're going to work with the neural system. And so there are some hospitals that still practice vasoconstriction or vasodilation by manipulating CO2 levels. Some hospitals say it doesn't help, some say it does help. But what that means is you're going to try to manipulate the outcome of intracranial pressure to reduce pressure on the brain by hyperventilating a patient to blow off the CO2 levels. Things like that you don't normally think about in a regular ICU. In a trauma ICU, you're going to be doing a lot of that kind of stuff. Another cool thing about the ICU is you're going to see a lot of really neat cases. Sometimes it's very tragic. You're going to see things that you're just absolutely you can't get over. You're gonna go home and think about it. You're gonna be constantly thinking about how sad the situation is. And oftentimes the patient's really good and healthy, but it's just a really rare thing that's going on with them. And it's pretty interesting because you only read about it or you see it in movies, but then you finally see it in person. And you're like, oh, this is really cool because I've been reading about this for years and I finally get to see it. And so that's something that you're going to most likely see or at least have a higher chance of seeing in an ICU. Now, ED. And ED for day shift. Again, day shift is most likely when you're going to see crazy stuff. Night shift, you're going to see a little bit less crazy stuff, but you never know. Sometimes night shift is way more busy than day shift. So, ED. You come in again at 6:45. You get your report for whoever's in the ED. I keep saying ED. It's the same thing as ER. Emergency room is more likely like a room in the emergency department, but the whole department as a whole is usually called ED or emergency department. A lot of hospitals have a trauma bay and emergency bay and other bays, and so the whole area is just called the emergency department. So if you're working in a hospital, it's called ED, not the other kind of ED. So you get your report. It's 7 o'clock, 7:15. You're done with your report. And the flow of work as an RT in the emergency department is going to be a little bit different. Actually, it's going to be very different. So you get on shift. The first thing you do is after you're done with your report, you're going to go down to the ED and make sure that you have all your equipment because you never know when things are going to get bad in the emergency room. So when you're going to go there, you're going to make sure that you have all your vents ready, all your BiPAPs ready, any airvos, high flow nasal cannulas, vapotherms, any equipment that you use in your hospital. You're going to make sure that you're fully stocked, that you have everything ready, and you have some backup emergency or intubation kits. My routine personally is I like to have 1 or 2 intubation kits. What I put in an intubation kit is just everything I'm going to need in an intubation. So what I do is I just quickly grab the bag that I already made and I go to an intubation. That way I'm ready and we could pretty much tube the patient within 5 minutes. If you don't have this ready, it just kind of becomes a little bit more flustered. Or I guess you get a little bit more flustered because the RSI kit sometimes doesn't have everything you need. Sometimes there's no ET tubes. There's no syringes. If they have a crash cart, you don't always have everything you need there. So it's better to just be prepared, come in, set up 1 or 2 bags. The next shift, if you don't use it, is going to be very grateful and thankful for that. I usually put a capnography device to measure my CO2 inside of it. What I usually put inside of my little quick intubation bag is a capnography device, an easy cap, something to measure the CO2 levels after the patient's intubated, some kind of Hollister or securing device to secure the ET tube. I get a suction ballard. I do know some people that get both a trach and an ET one. I just get the ET one because you're not going to see a trach that frequent. You're just going to end up wasting it. I do get a PEEP valve every single time. You never know when you have a difficult patient. And I usually don't use the PEEP valve and take it out if I know the patient's not going to need it. Beyond that, sometimes if the ET holder doesn't have a bite block, I'll get a bite block and I'll get a syringe in there. So that's pretty much like a quick little setup. I do sometimes put in extra things like end tidal, CO2 monitor, or like an HME, something really quick. All these words will make sense if you're just starting your job, if you've been exposed to it. If you have not been exposed to being an RT and this is your first time being exposed to these words, then ask me about it. I'll love to make a video explaining what each one of these devices are. But beyond that, you make your little setup bags, you go check your vents, make sure they're all calibrated, make sure everything is good. Once you're done doing that, the ED flow is very different because you don't technically have any actual assigned patients unless they're left over from the night before. So in an ED setting, anything can happen throughout the whole day. So one of the things you might get called throughout the day, and it depends on the size of your hospital, is going to be a procedural sedation or a conscious sedation. A conscious sedation or a procedural sedation is when a patient has to get sedated to do some procedure. So they're going to give the patient a medication that makes them a little bit sleepy, and that's going to be something like propofol or ketamine, depending on what's going on and also their blood pressure and things like that. So for these procedures, you're going to have something like a dislocated hip, or I've seen some pretty gnarly stuff. Eyeballs coming out and they had to try to put it back in, and so they sedate the patient and then they can actually work on the patient. Your job as an RT is to make sure they continue breathing the entire time. So you're usually holding an ambu bag or near an ambu bag, you have suction set up, and you're ready to intubate the patient if they need to get intubated. Whether it's you intubating or the doctor, you're there to make sure that they're able to breathe. Now, for procedural sedations, they're usually very low risk. You don't see things happen that like wrong. But there have been times where I had to hold up and do a jaw thrust maneuver, which is just to make sure that the airway stays open. So you just kind of push back the jaw, and then that way the airway doesn't collapse right here when they're heavily sedated. But for the most part, everything's been fine. I've never actually experienced a situation where I had to bag or use the ambu bag. But every single time I've been in one of these situations, I was ready. And that's kind of what you're there for as an RT. Another thing you're going to do in an ED is going to be small volume nebulizers or any kind of quick treatments, maybe inhalers. For the most part, if your hospital is big, you're going to have nurses doing it or maybe backup RTs doing it. If you have a little bit of a smaller hospital, you're going to be doing all the work yourself. And so, again, it all depends on how many orders come through. If you're getting 10 orders at the same time, you're obviously not going to make it. And so in that situation, you just ask your nurse, can you please do the treatment for me? Small volume nebulizers and just quick nebs and MDIs are probably the least of what you're going to do in an emergency room. What else you might see and encounter in an emergency department, if you work in a trauma center, you're going to get a lot of traumas, a lot of car accidents or shootings and stabbings. I worked at a place that maybe had like 3 or 4 a day on average. Some days were heavy, some days were light. But in those situations, you got to drop everything you're doing and you got to go to the trauma. There's usually somebody else coming with you to make sure it's okay. Most hospitals will have a system where they differentiate between how severe trauma is in the call that they do or on the beeper that you get. And you'll get called to a full trauma, which will tell you that you need help coming in your way. So in that situation, you usually get your SpectraLink or whatever phone you have and call back up and say, hey, look, we're getting a trauma, just in case you didn't hear it. A lot of hospitals, by the way, have pagers, and not many people know why they have pagers. The reason hospitals and doctors and a lot of people still have pagers is because many hospitals are old and they have lead paint and lead walls in the surgery units, and cell phone signals don't get through the walls. So a pager, the signal that's sent can penetrate through even elevators. So while you're on an elevator, you won't get a call, you won't hear the signal, but your pager will get a beep. And so that's why hospitals still use pagers. It seems a little bit like a hospital is just outdated, but it's actually practical. So now this is the reason that you're there in the emergency room. It's going to be the intubations, the code 3s, which means that the ambulance is coming with lights and sirens. It's going to be your respiratory failures where you're going to put people on a BiPAP, or most recently with the pandemic, it's been patients that have been needing a lot of oxygen. You're going to go to those things. That's kind of what your biggest role in an ED is. So even though you're going to see procedural sedations, you're going to see some nebs, maybe some teachings, some quick inhalers or an ABG here or there to make sure a patient's stable and okay. The biggest reason why you're in an ED is because there's going to be a lot of people coming in that can't breathe, or they're going to be coming in getting CPR from the ambulance, or whatever the case may be, and you're going to be doing a lot of that. While you're in the ED, the role that you have is a little bit different than the floors, because in the ED, your number one job is to make sure the patient doesn't die and they're stable, as opposed to an ICU where your goal is to make sure that you get the vent off of them, make sure that they can go home, make sure they can do things. You're not worried about the long term as much in an ED. So when the patient comes in code 3, ambulance is bringing them lights and sirens, they went into cardiac arrest on the way to the hospital, you're waiting to intubate them to make sure that they can actually blow off any excess CO2. As soon as you get there, they get intubated. You continue bagging them. Once the patient's heart comes back, you're going to get an ABG and you're going to make sure that they're safe, they're okay. You're going to see a lot more bloody stuff. There's going to be a lot more blood in the ED. If that's what you're afraid of or you don't like seeing, get ready for that, because that's what you're going to see in the emergency room. The ED is very fun for people that like to fast-paced, energy, kind of adrenaline rushing things. In the ICU, you do have those moments where you're going to have an adrenaline rush, but in the ED, especially in like a trauma center, your whole shift is just one big adrenaline rush. You're going to be so beat at the end of the day. You're going to be working really hard to make sure everybody stays alive, everybody's okay, and you and the whole team is going to work together very well. Because there's so many situations that require teamwork, you're going to get so good at working with people in the emergency room that it's going to be fascinating. You won't even realize it until you're in the moment and you're like, wow, this team is working really well together. During like a code where they're doing CPR, it's going to be a little bit different than what you experience on the floors or in the ICU. In the emergency department, everybody there is coming to help you. There's like 30 people there willing to do something. Everybody's getting something. Everybody's running to do something. Everybody has such adrenaline rushing through them. And it's a different experience having a code blue in an ED or in a trauma center than it is having one in the ICU or on the floors. Every one of them have their own feel. Every one have their own rhythm. And in the ED is probably some of the best places you're going to have a code, because everybody's just always waiting for that to happen. And so everybody's just on their feet, running around. It's pretty interesting. So the routine or day in the life of an RT in the ED, it's not really scheduled. You're just going to be kind of getting called throughout the day or hearing your name paged over the intercom system, but you don't necessarily have a routine. There could be an hour where you don't do anything and you're just kind of waiting. And in that moment, you're kind of reading up on the patients you do have, or you might be even bored, honestly, at times. Oftentimes, though, you're not going to be bored and you're just going to be one thing after another thing. If it's a busy hospital, what happens is you're working, and while you're doing something with the patient, like let's say putting somebody on a BiPAP because they can't breathe, you're getting a call to another room because they need a continuous, an hour long or like a few hour long breathing treatment because they're having an asthma attack. If you work in an ED that has both pediatric and adult cases, you could have a 90-year-old patient who has CHF that you're helping them breathe one moment, and within 10 minutes you could have a 2-year-old or a 1-year-old that you're giving a breathing treatment to because they can't breathe because they have asthma. And it's completely a different vibe, a different experience, but you always got to be ready. You're always on. You're always ready to go in the ED. That's kind of how your day works. When you go to lunch, somebody's going to most likely cover you because you can't just leave the ED. You never know when things are going to happen. You never know when an ambulance is going to come or when somebody just crashes. So that's the day in the life of an RT. In the daytime, it does tend to be a little bit more busy. I don't know if people just don't want to go to work, so the thing that they've been holding off for a few days, they finally go, or whether there's just more things that happen during the day because there's more work, more things going on. I have noticed that Friday nights when people are partying and drinking, you're going to have a lot more DUIs, car accidents, things like that. Monday morning, you're going to get a lot of people that have been holding off the whole weekend going to the hospital, and they're pretty bad. You're going to start seeing things like that. It's not always the case, but there is going to be influxes of patients that you could kind of predict. And that's kind of what you're going to get used to as an RT in the ED. And finally, floors. This is most likely the best part of your job. You're going to be a neb jockey. Most likely in a hospital, you're going to get assigned 1, 2, maybe 3 floors. I think at times I've been assigned 6 floors just because every floor only had about 1 or 2 patients. So your assignment can vary from 1 floor or half a floor all the way to the entire hospital, depending on how slow it is, also depending on how critical or not critical the people are. Like the ICU, you get points here. The points is determined by the work that you do during your shift. So like inhaler treatment is going to be either 5 minutes of work or 10 minutes of work, and you're going to get points assigned for that specific treatment. And on the floors, how you're going to start your day is like this. At 6:45, you come in, you get your report, you get everything ready. You leave around the same time that you leave to go to the ICU, so anywhere from 7 to 8 o'clock. You have 3 times you're going to have to see them because most medications are Q4. So you're going to be 8 o'clock, 12 o'clock, and 4 o'clock. And you have an hour window before, an hour window after. Same thing as the ICU. You're going to have a little short window where you get to do your treatments to see them. It's going to be a little bit different though because it's not an intense situation and you're going to have a lot more busy work. So on the floors, it's a lot easier. Patients are more stable. The people are talking, laughing. Sometimes they're eating breakfast, and that's actually a big obstacle you have to deal with. So you get there around 7 o'clock, try to beat the lunch trays or breakfast trays, And when you're giving them a breathing treatment, you see dietary or whoever bringing them in breakfast, and they're like, I don't want to do my treatment anymore because I got to get my breakfast. And that's a lot of the obstacles you have while you're doing the floors. Sometimes a patient left the ICU and now you have to follow up with them and they are pretty critical. Those kind of people, you will spend a lot more time with them. There's patients that I have about an hour of treatments per each round just with one person. So you're in the room for almost an hour doing stuff to make sure that they could breathe. Those patients are usually very critical. They might be on some kind of high flow nasal cannula. They might need a lot of CPT, and they might have just like 6 things ordered for them. If you work in a place that has a lot of cystic fibrosis patients, those patients usually take about an hour, maybe half an hour to an hour each round. And you get to really get to know these people. So it's a completely different experience in the ICU because each round you're actually going to spend a lot of time talking to these people. You have about 10, 15, maybe 20 minutes in a room on average. And you're talking to these patients, they're asking you how your day was. And once you're giving the treatment, you're kind of there just to monitor to make sure they're okay. So it's not like you're there to make sure that they don't die. You're just there to make sure they don't have an adverse reaction to the medication you're giving them. You're also making sure that they're getting the treatment. Sometimes the patient's sleeping or getting really sleepy, and you notice that the thing keeps coming off, the mask, the nebulizer. So you're there to make sure that it stays on and they get everything. So from 7 to 9, you're doing your treatments. Oftentimes from 9 to 10, you start doing your inhalers because most patients on the floors have chronic conditions like COPD, and you're going to have to give them some kind of inhaler to maintain and make sure that they don't get any worse. And so from 7 to 9, you're giving your breathing treatments like SVNs, albuterols, ipratropiums, budesonides. And then from 9 to 10, you're giving your inhalers, Advairs, or anything else. After that time, from 10 to 11, you're pretty much in a place where you're catching up on what else you might not have done yet. You might have gotten a new patient from the ED or from the ICU, and now you got to go see them, assess them, do what else that needs to be done. During that time of about 9 to 11 or 10 to 11, you're going to have a lot of either help or you're going to help others because you never know how bad things might get on the floors. You might get a perfectly good assignment and all of your patients crash. Just out of nowhere, that happens all the time. You might have a code blue, an RRT. You really never know what's happening with your patients. And especially if you have 2 or 3 floors, there's a lot of area to cover. So in that time period is when you're catching up or you're helping other people catch up so that later on they can help you out. Working on the floors, because it's not as intense as the ICU, you might have a little bit more time to have lunch now. So typically a lot of the people that are working floors as opposed to ICUs, they'll get their lunches before the next treatments. That way the ICU people can get their lunches afterwards. But it depends on the hospital you work at, depends on the policies that they have in place. What happens after this now? You start your rounds. Again, 12 o'clock rounds are due. So you start around 11 o'clock. You try to catch up. At this time, you'll have a lot of new people that came into your place. So you're assessing them. You're also doing a lot of things to determine whether they need any more treatments, less treatments. You're evaluating their care. And if there's any ABGs, you're kind of doing everything that needs to be done to make sure they're going to have a good day in the hospital. After 1 o'clock, you're again free for about another hour. Usually at this time, you'll be utilized by any other staff members that need help. If you're not utilized, you do have a little bit of free time, maybe about 30 minutes to kind of just go and read up on your patients. Because you have a lot more patients, it does take a lot longer to read up on them. Not everybody has an intense history at this point, but you do want to read up and spend some time at that time reading about them. And then you got your 4 o'clock rounds. Your 4 o'clock rounds are going to start around 3 o'clock, like I said. You might have some Q6 treatments where you needed to do them at 2 o'clock. That happens throughout the hospital. You might have some off times that you might have done to the patients where somebody was started later or the medication was ordered at a weird time. But after that time period, you're going to get a lot of discharges usually around your last rounds if you're working day shift, and you're going to get an influx of new patients. So it's kind of an interesting time. It's a problem, not necessarily a problem, but it's a thing that happens in every hospital. Right around 4 o'clock, a lot of people get sent home or to skilled nursing facilities. The doctors already evaluated them. Everybody's already kind of did what they need to do. And then nurses start discharging patients. And between 4 o'clock and 8 o'clock, there's going to be a lot of new admits. And that's when you got to kind of be always checking to make sure you got any new things that you need to do. And you're watching that. It's almost a guarantee that you're going to do at least 2 or 3 treatments that weren't planned for during that time. And same thing for nurses. The nurses are going to be having to do an admit, and they notice the patient needs some kind of medication because they're wheezing. So you'll start a lot of new treatments at this time. During that time, you have to educate the patient, kind of teach them what to do. If there's any discharges, you're going to give any kind of medications home, do any kind of teachings home. If there's any oxygen that needs to be delivered, that's when you're going to do that. So your last rounds are kind of a random little mix, more like the ED where you don't know what to expect. You do have your patients that you were assigned, but you probably have at least 10 new patients that you didn't even know about, and now you're reading up on them and getting to know who they are, introducing yourself and doing all that. After that, you're going to get your report ready towards the end of your shift. And now finally the next shift of RTs came in, so you're giving them report, you're handing off everything to them. Night shift floors is actually very different than day shift floors, because night shift floors, most treatments are Q4 while awake. Not most, but a lot of treatments are done while the patient's awake and not sleeping. It's kind of better for the patient to sleep at night as opposed to you waking them up and giving them some kind of treatment. Unless they're really, really bad, it's better for them to sleep. And because of this, nighttime RTs usually are very, very busy their first 4 to 6 hours. So starting at when you get there at 7 o'clock at night till about 11 or 12 o'clock, you're going to be running around like a chicken with its head cut off because you have so many things to do to make sure everything's okay so the people can sleep. Once they go to sleep, though, you're going to have a lot less treatments. And because of this, nighttime RTs usually get another responsibility in most hospitals. So whether it's changing nebulizers or doing some kind of hygiene thing, turning around vents, you're going to do something else at night because there's going to be a little bit less work for you to do. So there's going to be some kind of extra requirement to do. But for the most part, you still are going to be very busy, just like you were in day shift. It's just you're going to be more busy your first half than your second half. Your second half, you're probably going to get half the patients that are sleeping. You don't have to see them anymore. And so in that situation, what you're going to do is you're going to be helping out. You're going to be doing anything else that can be done. Thank you guys for watching. If you guys like what I said, if you guys approve, disapprove, agree, don't agree, if you're already an RT and you don't agree with what I'm saying with the schedules or with how things work, let me know in the comments. If you have any questions, I love answering your guys' questions. Thank you guys for watching. Stick around for the next video. Have a good day.